12-lead rollout. What we're going to try at Winsted emails. Just as a disclaimer, it is a state-approved rollout, so there are certain slides in here that cover what the state requires us to cover and talk about. Okay. So Tom originally created a presentation. I made some edits to it for us in regards to the devices. So cognitive, we are going to talk about the purpose of 12-lead ECG acquisition, and ECG is interchangeable with EKG, same idea. So we're going to talk about why do we acquire 12 leads, what are the indications for acquisition as well as transmission of the EKG, the importance of the anatomic location of the lead placement as well as the preparation for when we place the leads. And we'll talk about what causes low quality of the EKG, what are some of the artifacts, what can we do to minimize that, and manage patients' anatomical variations that could interfere with the ECG placement. Okay. So you're going to need to appreciate the impact that it has if we do this. Why are we doing this, right? There's a benefit to obviously this in the management of the ACS, acute coronary syndrome, and excuse me, there's also a value that we're transmitting that is per the AHA. So the AHA has shown, and there's studies that have shown that if you transmit a 12-lead EKG to a facility and it changes maybe where you take this patient now to a cath lab if they have a STEMI, that the patients tend to benefit from that. We're going to go through the placement of the leads. We're going to go through the monitor. How does the monitor work? We're going to go through how do we, after we acquire the 12 lead, what do we do with it? How do we transmit it? Where does it need to go? And all of that. And then we're going to do a couple of case scenarios, and we're going to talk about what would you do in those case scenarios that are relevant to this, and then just we're going to demonstrate that you know how to acquire it and how to transmit it. Okay, so why are we doing a 12-lead EKG? We're doing a 12-lead EKG because we're trying to figure out, does the patient have a STEMI, an ST elevation myocardial infarction? And there are other types of myocardial infarction, but that is generally what we're after, is the ST elevation in mind. And the reason why we're doing this is because we want to triage them. We want to get them to a facility that can do PCI, percutaneous catheterization, get in there, get into the coronary vessels, and open them up. Okay? Charlotte Hungerford is not a facility that can do that. Winsted Health Center is not a facility that can do that. Waterbury, St. Francis, St. Mary's, Hartford, all of those are facilities that have that capability. And then we're going to focus, or the whole focus on all of this is that we want to save time, right? So we want to get the patient to this intervention as soon as possible. Time is tissue, time is muscle, those are the statements that you will hear in conjunction with this. Okay, so the 12-lead EKG is basically cameras that look at the heart, and they look at the heart from different angles. That is what this picture here is supposed to show. So as these multiple leads are applied, they're looking at the heart from different positions. Looking at the heart from different positions allows you to identify issues with different portions of the coronary artery structures. The right coronary, the left coronary, etc. Now, when we talk about this, we go into details of identifying coronary arteries and all of that. None of that is really applicable at the BLS level, right? You basically are going to apply the leads, you're going to acquire the 12-lead, and you're going to transfer. But nothing changes for your care. You're going to care for this person as if they were a coronary syndrome patient, and despite of what the monitor says. It's a little bit like pulse ox or something. If somebody tells you they have shortness of breath, and their pulse ox is 93 or 94, you're still going to give them oxygen, not because the pulse ox says they're 94, they're not going, right? Similar with the 12 lead, if the 12 lead end up saying it's nothing, you're still going to treat it as if it was something, okay? So the leading cause of death in the United States still today is that of an MI or of a coronary artery syndrome or disease process. And almost a third of the people, or actually a third of the people, is affected by this. And it causes quite a large rate of death, and the deaths are often caused pre-hospitally and are caused by dysrhythmias or the failure of the pump. So what is CAD? What is coronary artery disease? Coronary artery disease is a buildup of plaque. So in here, you have a cross-section of an artery, of a coronary artery, and you see that yellow stuff is the plaque buildup. Here you have the different stages. As it starts building up, it builds up more, and it closes the lumen of that artery. So it's like a garden hose that you take and you squeeze it tighter and tighter and tighter, and there's less blood flow. And at some point, there's the potential for that completely to occlude, okay? If it completely occludes, your heart muscle is not supplied with oxygen. If your heart muscle is not supplied with oxygen, it dies. Heart muscle is a type of tissue that does not rebuild. So once it's dead, it stays dead. So the goal is that we're going to reduce the amount of muscle that gets damaged or dies, and then we open that vessel back up. So there's risk factors. Some of them you can change, some of them you can't change. So you can't really change your age, right? That is a risk factor. The older you are, the more likely you are to have cardiac issues. Hypertension, diabetes. Some of these are illness processes that you cannot change, but you can manage. And you can manage them well, or you can manage them poorly. Tobacco use you can change, physical activity you can change, hopefully you can lose weight if you need to. So some of these are modifiable, some of these are not. And then there's always this question, so when are we going to do a 12 lead? Nothing? So obviously the question is, when do we do these, right? So when are we going to do a 12 lead EKG? And it is not that we're only going to do them on chest pain or chest pressure patients, but rather on a larger population. And one of the reasons is that not all patients present with chest pain that have an MI. There's actually quite a percentage of people that present very different. So for example, they could present with just epigastric pain, right? So what people are more likely to have an unusual presentation of an MI?
Women.
Women, yeah. What other population?
Obese.
Some, yeah.
Obese.
Obesity, yeah. What are some of the people that may not feel the pain because of their illness process? Diabetics, right? For example, diabetics tend to have MIs and not necessarily have the typical signs of chest pain. Your elderly is another great population to come with very sort of vague nausea, vomiting, sudden onset. Oh, they could just be sick. They could have eaten something wrong, or they could have an MI. Another one, profound weakness. You have an elderly person who is living alone at home. The home is very clean. She vacuums. She does everything by herself. She's very mobile, agile, moving around. All of a sudden, one day, all of a sudden, she feels weak and she stops moving. That could be because she's having an MI. Okay? So it is not required that this always occurs. That is not true. So don't just look for, oh, chest pain, 12 lead. If it looks like it could be in the 12 lead, do a 12 lead. Okay. So obviously if they have previous cardiac history, and history is a very interesting thing, medical history. Ask what their family history is. If they had a young sibling, or their mother or father died very young of a heart attack, for example, they're at tremendous risk. right? So that's another great group of people to do a 12 lead on. There are really no contraindications to perform a 12 lead. It doesn't do anything to the patient. The only thing that a 12 lead does that you could construe into negative is that the time that it takes to perform it. But when we did it earlier with the earlier group, the whole thing with people that hadn't done it before, we were looking at 3 to 5 minutes, including the transmission of the 12 lead. So you're looking at about 5 minutes or so. Generally, that should be okay. That should not be something that now affects the patient detrimentally. So there are really no contraindications. And if in doubt, perform a 12 lead, just do it. Not all myocardial infarctions show up on the EKG. So you may perform an EKG and the 12 lead says it's normal, there's no issue, and this person in fact has an MI. Okay? So that's why I'm stressing, do not look at this or whatever comes out of that box and say, that's gospel, this is it, okay? Look at your clinical presentation, and if your clinical presentation is such that you feel they're having something cardiac or something, you treat that. You manage that, regardless of what the machine says, okay? It can also change very quickly, and that's why we really want to do it early. Ideally, we want to do it in the house, in the chair where we find them in, if we can. Okay, the earlier the better.
Is this before or after aspirin?
And I would not necessarily before or after. What I would say is maybe one person can work on the 12 lead and the other person can work on the aspirin administration. The same with oxygen or something. One does not have to delay the other.
Okay, well, I didn't per se want to say that it delays it, but
okay.
do you want the EKG before you give the aspirin, or do you want it after you give the aspirin?
There's no rule.
There is no rule for that? It's not going to affect it?
Well, so the earlier they get the aspirin, the likelihood of it working earlier is there, right? And I don't know, just as a refresher, aspirin is not a clot buster, right? So if I have a clot in a vessel and I give this person aspirin, it does not magically dissolve this existing clot. What it does is it stops additional pieces to stick to whatever is there. It's called platelet aggregation inhibitor, right? So there's a clot there and it blocks, and more stuff starts trying to hang to it, and aspirin stops that additional hanging to it, but it does not poke a hole magically in it. It is not TPA or like a lytic, right? That is not what it does. But it is beneficial in particular at the cost and the risk profile of it. It's very beneficial to do it early. How much aspirin do we give? For what?
380 milligrams.
Huh?
380 milligrams.
So it's 81 milligrams per pill. How many tablets? 4 tablets times 81 is 324, right? What's an adult aspirin? 325. It's just off by 1. But it should be the chewable kind, because the chewable kind gets dissolved and taken up in your buccal stuff and mucosa and all that, not in your stomach, right? Ideally. Okay. All right. So there's some other things too, is like the whole transporting piece. If one person is working on the 12 lead, the other person may be able to start prepping for the transport. So I don't want that machine to become sort of tunnel, that's all we do and I forget about everything else, right? Because ultimately we're there to move the person from A to B. Oxygen. Don't delay oxygen just because you're putting stickers on, right? Put them on oxygen, then put the stickers on. Or have your partner do it, or have the police officer do it, whichever. Okay. So, what is the acute coronary syndrome? Again, it's not one thing, and they call it a spectrum of symptoms. There's, I mean, most of you have probably heard of angina or angina pectoris or something, and they call it here's unstable angina. There's myocardial infarction. There's different types of infarctions. There's NSTEMI, there's STEMI, blah blah blah. All of this stuff is sort of good to know in the back of your head, but this is not really going to matter when you do that. when you acquire the 12th lead, okay? There's injury patterns, there's ischemia, injury, and infarct. It is the levels of what happens to the cell. What point is the cell at? Is the cell salvageable, or is the cell done? And this happens, this time is what matters. So the faster we do something, the better for the patient. The faster that gets opened up, this vessel that is clotted up with in the cath lab, the better, or with a lytic. All right, so here they present it as the typical kind of book MI, right, or acute coronary syndrome. Somebody who's clutching their chest, with the face sweaty, pale, all of this, right, so the typical presentation. And it does happen, but then it also happens that it's atypical, okay? Okay, so, and in this picture, you had said females, right? They took a female and she's grabbing her arm, right? So it is possible that you have a patient that their only presentation is a sudden onset of left arm pain, for example. So I'm sitting in front of the TV, I'm watching TV, and all of a sudden I have a shooting pain in my arm. I've not done sports, I've not done heavy lifting, I've not been in a fight, I've not fallen. There's no reason for this pain to be. I don't have any neuropathies, neck issues, or anything like that, but all of a sudden I have this constant pain in my left arm. I have no chest pain, I'm not short of breath, this is it. That is possible to be an MI, okay? And as they say here, 33%, so a third, complains of things that are not typical that have an MI. Okay, so it's definitely a number of the population. We already talked about this, women, diabetes, older patients, prior heart failure. That's the population that this may happen to, okay, that we need to be even more aware of. Okay, so when you interact or take care of a ACS patient, you do your routine EMT care. Routine EMT care is taking vital signs, putting somebody on oxygen, the typical stuff that we do for almost all patients. We want to do this early, right? We want to get a paramedic there early. A patient that experiences an MI is very much at risk to have a dysrhythmia, right? That is one of the problems that they run into. We can treat it with the AED to some degree, but a paramedic can better treat it, right? They can also do a couple more things for an MI, so we definitely want the medic there if we can. We want to perform a 12-lead EKG. So out of this whole thing, really, the 12-lead is the only thing that we're not doing yet. We already are doing this, we're already doing this. We're already assisting with nitro for propofol, right? All of that we're doing, we're just adding 12-lead, okay? Okay. So, ideally, we obtain this early on. You have the patient is sitting on a couch or something, you ideally do it right there. One of the big reasons is it changes. And it can be a STEMI picture on the couch, you bring him out in the ambulance, and it looks normal. Right? It's possible. If you would have not acquired it here, you would never have that picture. Hospital may never have that picture, right? So it is beneficial to do it as early as possible. The other big benefit we have over the hospital is, what does the hospital, when you do a 12-lead in the hospital, what do? You go up to the patient, you apply the stickies, it prints out, and then what do? You
Walk it directly to the physician.
What do you do with your machine and the cables?
Take them off.
What do we do?
Leave them off.
Correct. So we do better than the hospital when it comes to 12 leads, because we leave the machine on and all it takes is one button push and it will acquire another 12 lead. So we can do what is referred to as serial 12 leads. That can be very beneficial, okay? So we can add something that generally isn't done in the hospital. Okay, so we acquire it, ideally early, and then we transmit it to the hospital. We're going to transmit to Charlotte. That's the only place we're going to transmit to right now at the start of all of this, okay? And then we contact med control, and then they give us some instructions, or not. Say, come on. So how do we do this? How do we obtain a 12 lead? So A 12 lead is really not 12 cables, it's 10 cables. And a computer makes up some of the other leads. So we apply 10 cables. Each cable, each lead is a view, almost like a camera. So when you take the heart in the chest and you apply the leads, it's almost like you're standing there with a camera, you take a picture, you move over a little bit, take a picture, you move over a little bit, take a picture. So you do a view around it, right? And if you look at the slides here, so I would be taking a picture from the front of the heart, and then I start working my way around to the left side. Why do I go to the left and not the right? Can I go to the right?
Yes.
Yeah, okay, so there's right-sided EKGs, yeah. Can I go to the back? Yes? Okay, so could I go to the left back? Or right back? Where is it going?
I remember.
So left back, yes, right back, no. So it's left, right, and left posterior is generally what is done, not by us. We're just going to focus on the left front. Why do we just focus on this? When you look at the heart, so your heart sits in your chest, it sits a little bit to the left. What is on the left? Which ventricle is on the left? The left ventricle. Okay, all right. So we got that. Left ventricle. What does the left ventricle do? It pumps blood, just like the right, just like the atria. That would have been a very safe answer. It pumps. Okay. It pumps into your aorta, right? It's your high pressure system. It's what the oxygenated blood pushed into your body. That's your left ventricle. It's the bigger muscle. It's the bigger part. It's the more important piece of your heart if you wanted to, if you had to vote on it, right? So we generally look at the left ventricle. If your left ventricle poops out, you've got big issues. If your right ventricle poops out, you have issues not as big as your left, okay? So that's why we generally look at this, okay? So we talked about other types of ECGs performed. There's even more, but we'll just leave that where it is. And what is this diagnostic versus monitor quality mean? So if I take 4 leads of that monitor and I apply them to you, is that diagnostic level? No, it's a 4-lead EKG, it's not diagnostic level. If I perform a 12-lead EKG, it is considered diagnostic, it's calibrated, everything is measured, set up, blah, 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 right? So there's a difference between 4 and 12. We want 12. There's also 15 lead, quite frankly, and blah. But we'll focus on 12. Okay, so we acquired when we first see the patient. Like to explain to the patient what are we doing, right? Because you're going to bare their chest and all of that, so an explanation is always good. You want to have them in a comfortable position. You don't want them having to tense up. You don't want them to have any muscle contraction, anything like that. Nice and easy, nice and relaxed. You got to expose their chest, so protect their modesty. Not the back doors open, or if the ambulance, if you do it in the ambulance, not the whole family come on in, take a look at what we can do, right? Prep the skin and attach electrodes. So the skin prep. Ideally, we shave heavy hair off the chest, right? With a specific shaving tool that doesn't create cuts in the skin, because the cuts in the skin are not beneficial. Ideally, we use a sandpaper under each electrode, okay? So that's very close to Tommy's heart, so the next lecture that he does, he's going to probably emphasize that more. But that is what you're supposed to do. It's supposed to be dry. It's supposed to be not having hair. It's supposed to be the dead skin sanded off, right? And then you apply the electrode. Okay. You want to have the patient relax. So this is one thing that I added to this. Why do I want to cover him up to the chin with a blanket? Yes. How do I do that? Why does the blanket do that? Nope. So even if you can't see it, the patient may be shivering, right? It's something that's not visual, but there's still shivering going on. If you cover them with a blanket up to here, you can reduce some of that, and your EKG will change. Not on all patients, doesn't work all the time, but it does work, okay? You can put a blanket on the electrodes, not an issue. And so the more you cover them up, the less shiver you have, the less artifacts you have. You acquire the EKG, and then we'll talk about the specific steps that we're going to do with this all. Okay, so here's that shaving tool that I was talking about, that it leaves something like this to this. I don't believe that, but okay. And so you prep prior to the acquisition, remove hair, dry skin, and sugar electrode contact. And if you have poor prep, then you have poor quality of the EKG. Okay. All right, what is this? Correct. They're called, what kind of leads are those? Limb leads, very good. So when in doubt, look at the slide. It's going to be on the slide, okay? That's always a good bet, yes, yes. What leads are these? Okay, so these are limb leads, okay. So are we going to do this one or this one? Does it matter?
The closer the better.
Why?
Because
Less
it
artifact
gives you a
going
better.
between one to one.
Say it loud.
I said less artifact
Artifacts, yes.
for the signal going between two.
Correct. So notice a theme here, less artifact, less artifact, less artifact, right? So we're going to try to do the best we can to reduce any artifact. So please use this. This is correct by the book. This is how it's done in a doctor's office, where it's nice and warm, where they're not having an MI, whatever, or maybe it's not warm, but in more ideal situation than we probably operate in. This creates more artifacts, so move them closer. How close can you move them? Well, that's why those red lines are there. Do not move them on the inside of the chest, outside of the armpit. So your armpit is one line, right here, right? If you draw a straight line, shoulder is okay, here is not okay. It's okay, not okay. Keep them on the arm, as close to the chest as you can, off that red line. The same is true for the lower ones. There's your inguinal hernia right here, not hernia, why do I always say hernia? Ligament, god damn it. So, ligament right here, right? Off this, yes, okay, up here, not okay. Will you see it done differently? Yes, you will. By the manufacturer, by the calibration, all of that, this is how we're going to do it. Okay? Okay. How do I place them? Right arm, left arm, right leg, left leg, they're labeled. Just like as you see the abbreviations, that's actually on the electrode, not the electrodes, the cables, the ends of the cables. You can also use this. So, you can use either these acronyms down here, or you can memorize this, or whatever you want to do. It doesn't matter to me how, just do it right. Right? Simple. I use white is right, smoke over fire, leaves one cable. But you can also use clouds, white, over grass, green, smoke over fire, right? Black over red. Yeah, and if you screw it up, peel it off, put another electrode on, doesn't matter. Don't hesitate to use new electrodes, right? Because you want to reduce artifact. So if you need to use a new electrode, use a new electrode. If you need to use a few, use a few. Okay. So now we get to what we do on the chest, right? So there's 6 more leads we have to place on the chest. Okay. So I'm going to step forward here one to get a picture. I'm more a picture person, I'm not a word person. We place them in this fashion, right? So what does all this mean? Okay. So first of all, we have to figure out where is the 4th intercostal space, right? That's key piece. We have to find that 4th intercostal space. So if you take the clavicle and you feel your clavicle, right? Go ahead. This is where we actually do something. Yeah. And then push down. Below there, there should be a space. There's a rib underneath and then a space. Right? Just like in this picture. And the picture. So this space is your 1st intercostal space. 2nd, 3rd, 4th. The other thing you can do is if you drive down on your sternum, at some point you feel some nub or something, they call it, some prominence. If you slide across, there's a 2nd intercostal space. Okay? So this is not easy. If it were easy, anybody could do it, right? A caveman could do it. Okay. So, but you have to identify the space. Personally, for me, the clavicle works better. And then if somebody is exposed, it might be a little better, and you may have to poke a little. and it may be uncomfortable, right? But that's okay. All right, so we'll find the fourth intercostal space, and we put lead one next to the sternum. Done. First one applied. If we go back here, it's exactly what it says, right? Okay. What about two?
Directly across the sternum.
Correct. Right across, same level. Boom. Other side of the sternum. No problem. Which one are we going to do next?
6.
4.
We could. I usually do 4, but okay. Let's do 4. Okay? So, 4 gets applied in which intercostal space?
5th.
Fifth intercostal space. So I need to know where 4 and 5 are. 4 and 5, that's it. So I'm going to go, and I'm going to go in the mid-clavicular line, in the fifth intercostal space, and boom, I place a sticker. Forget the nipple. The nipple has no impact on any of this stuff, right? So the problem is, in some people, the nipple would be here, 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 or I don't want to say it. Never mind, I don't want to get in trouble.
Non-existent.
Yeah, so, but the nipple could be in a different place. Do not use the nipple as a landmark for anything, just forget about it, it's there. So mid-clavicular line, so if you feel your clavicle, here's your sternum, right, clavicle, and then go out to the shoulder. So somewhere in the middle of this piece, right, wherever the middle is a line straight down, and that is where you place it. So fifth intercostal, line straight down. You put 3 where? Correct, in between 2 and 4, right? And then where does 5 go?
Between 4 and 6.
I'm sorry?
Between 4 and 6.
Okay, so
Down.
some people do that. Some people apply 6 in the mid-axillary line, so this is your axilla, right? So I get a fine, so from the front here, anterior, posterior, somewhere in the middle, I find a line, I draw it straight down, I place 6. I'm okay with that. What I want to see is, it's not super clear in this picture, it's somewhat clear, that 4, 5, and 6 are in a horizontal line. If you're standing in front of that, or you're standing, the patient's standing up. You don't have him stand up, but we're just pretending. Patient stands up, I don't know where my mannequin went. Patient stands up, and you turn the patient sideways. I want to see that. I don't want you following rib curvature. That is not correct. Okay? Some books will say it, some Google will say it, and some pictures. It is a straight line. 4, 5, 6, straight across. Horizontal. Like that. Okay? Fourth intercostal space, across fourth intercostal space. Fifth intercostal space, mid-clavicular line, clavicle. 3 in between, and then 5, 6, enter mid. Forget the posterior, doesn't matter. Just these 2. Is that pretty clear? Okay. There's a picture of what is mid-axillary line and anterior axillary line. A straight line, straight. Okay. This thing is dying. So, pendulous breast tissue. Great word. Thanks for putting that in there, Tom. Should be lifted in a professional manner, okay? So there's different ways you can address that. You can ask the person himself to lift it, right? Then you're not touching their breast. You can ask a female partner if you have, or if there's a female relative or something they're okay with it, I don't know. But generally enlist the help of a female. Communicate is, I think, important. That you tell them what's going on, what you're doing, and stuff like that. Generally speaking, it's not a big deal. Okay, it seems like a big deal, and everybody's like, ooh, but it's not that big. I have not experienced it to be a big deal. Use the back of your hand, so that the idea is that you're not grabbing your lifting. Okay. Use a towel and other stuff in between. Personally, you're lifting their breast. This is probably good to do, but at the end, you're touching their breast, and there's probably no way around unless there's somebody there that can help you, and it will be okay. The EKG stickers have to go underneath, so the breast has to come up, and they have to go into the right positions. Breast comes back down. Okay. What is this? Artifact, yeah. Or electrical interference, if I read the slide. What kind of electrical interference? 50 to 60 hertz. So when you have this funny looking EKG line that should be like thin, right? Like these other lines and like that, it's 50 to 60 hertz interference. It's an electrical source of a different, like an electrical cable or whatever running around. I don't know, maybe they have their night light lamp across their belly or something like that. Unlikely, but that's what this is. So how do you change it? By removing the source of that 50 to 60 hertz interference. Okay. What is this?
Too much movement.
Yes. So how do you reduce it?
Ask them to stay still.
Mm-hmm.
If they're shivering, go to them up to the
Yeah.
norm.
Yes.
If you're moving in.
I was gonna say that could
ask
be back
them
the
to-
ambulance moving.
Uh-huh.
Yeah.
Yes.
Also try to keep away from bone.
Yes. Yeah, so tissue and stuff. Okay, so and prep the electrodes, maybe replace certain electrodes. Okay. Now, do you see this? What does this tell you?
That- Yeah, that's not gonna give you an accurate reading. That it won't be able to interpret
Mhm.
the picture that it took because
Yeah.
of all the artifacts.
This is the only thing you can get. It's the best you can do. You're gonna send it to the hospital?
Yes.
Okay, what's the hospital gonna tell you?
There's no artifact.
No, the hospital's gonna tell you they have an STEMI. Right here, right there, right there, right there, and yeah. So 2, 3, 4, and 5 is ST elevation MI, anterior lateral MI.
Well, I guess before I'd send it first, I'd see if I could get a better one.
Understood. But what I'm trying to say to you is, this don't matter, what you think don't matter, send it. Their problem, not our problem. So that's the other theme I want you to understand is, we're gonna do the best with acquiring a 12 lead, we're gonna do it fast as we can, we're gonna do it appropriate, and we're gonna send it. And then the rest, not our problem, their problem, okay? So if Charlotte doesn't have things set up, if Charlotte is not ready to deal with it, whatever, again, not my issue, their issue. We're gonna do the best that Winsted Ambulance can do for the patient. Oops. I just want you to send that EKG, even if that's the best, you can try another time, and if you can't get a better one, that's okay. Okay. The other thing I told the other group is, and I don't know if you can see that, this, if you look at just from here to maybe here, it looks like the side view of a fireman's hat, and that's one of the terms they give this, a fireman's hat. If you see a fireman's hat, like, so this is the shield in front of the hat, this is the actual head part, right? Maybe a little bit in front, and then the thingy coming out in the back. You have to use your fantasy a little bit, but that is a term, fireman's hat. Not good, not good at all, right? Okay. Other term uses tombstones, but this looks to me more like a fireman's hat. Okay? All right. Again, you're not required to know any of that. It's just additional knowledge. Okay. Wavy baseline down here, right? It starts trailing off. Again, computer talks about, so it sees a pacemaker in this, which kind of excludes any kind of diagnostic value of this for STEMI interpretation, but you have an issue here. You have ST elevations here, right? So it requires further evaluation. Again, not our issue, their problem, right? Send it, done. And then they can tell us what they want us to do. Okay, so this is to talk about how it can change, an EKG can change, right? So this is the same patient. Does it look the same?
No.
No. Up here, you have fireman's hat, right? This is not as clear. This is probably your best kind of sort of picture of that. So this is ST elevation 2, 3, 4, not really, and 5. So again, anterior, a little bit lateral MI, right? In the first one. What is this? No, right? Except then you can start talking, oh, it gets more complicated, never mind. So it can change, right? That's all you need to sort of have in the back of it. Okay. All right. So how do we do that? We explain it to the patient, we apply the leads, team approach, right? Somebody can do the limb leads, somebody can do the chest leads, whatever. Somebody get the bonnet already, it doesn't matter, right? Team approach. Acquire, it will auto print. All you do is 12 lead, acquire, you're done. The prints, you take the print out, you take a picture, you send it, you're done. Right? Easy peasy. Don't delay transport. Don't sit around and say, I really want to have this sticker here. No, I'm going to move it a little. No, don't do, right? Quick, done, go. Consult medical control. This is key, key, key. I'm very worried that they hear 12 lead and assume you're paramedic level. Make sure they understand we're not paramedic level. We're sending you an EKG, BLS 12 lead, whatever, BLS unit, right? Make sure somehow you get that in there, probably at least twice, because they have this many else, right? So, and repeat the EKG as needed. So we turn the Zoll unit on. This comes up. We press that button. We wait for the EKG to show up. So this EKG is just there for your verification that the cables have been placed, that the monitor can see the EKG. Please do not interpret this EKG. This is not for interpretation or anything meant for you to look at, oh, they're in this, or they're in 3rd-degree heart block with blah, 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 or junctional. No, it's not what it's about. It's just so that you can see, okay, the leads are working, click acquire. Okay? And then have the patient hold still until the whole thing is printed out, because these units will analyze and print at the same time. They will not analyze, finish analyzing, and then start printing. And it's very quick. It takes a couple seconds and the thing is done. Okay? And it prints, and that is it. No more than this. I am not making you put in age and date and gender and all this other stuff. I don't think that matters. They're only going to get these EKGs from us in a certain way, and that's it. And they're going to listen to our report. They have to listen to our report. If on the piece of paper you want to write stuff on it, an age, a gender, I'm okay with that. But I don't want you playing with buttons and trying to figure, oh no, hold on, is it 60? I gotta go back and stuff. It takes time. So it's really only 12 lead, acquire, it prints, you're done with the acquisition of the 12 lead. You now have a piece of paper. And then it looks something like this. The computer will interpret the EKG. If the computer says something like this, acute MI, it is likely to be an MI. Not a guarantee, not 100%, and the computer sometimes will spit that out and it will not have an MI. Please do not talk to the patient about what this said. This is not for you to now relate, oh, you're having an MI. No. It is for you to say, shit, they're having an MI. Where's the AED? Where's my suction unit? My BVM is ready, all of that. I want to be ready if they go into cardiac arrest. Okay?
But we're still not doing anything until we hear from medical control where we're going to go.
No, so what I would do is, so you have a chest pain patient, you arrive there, you do your 12-lead EKG, you print it out, you see this on the strip, pucker factor goes, right, it's all okay, it's all good, for some more than others, I know, Jimmy. But, so, now I'm more ready, so now I want to worry about aspirin, I want to worry, and ideally I've already placed them on oxygen, I want to worry about transport, I'm going to move the patient, I'm going to talk to medical control when I can, but I'm going to start driving to a hospital. I'm not going to sit there and wait, unless maybe the medic is 2 minutes around the corner and you have, that's your intercept point, okay. But generally speaking, move with purpose, right? Move with purpose to a facility, right?
So, again, where are we heading? Because, I mean,
Charlotte.
We're heading to Charlotte.
Yes.
No matter what.
Yeah.
Pretty much.
And then when Medcon on the way tells you, no, this is STEMI, I understand your BLS, I want you to continue to Waterbury, then you're going to change your destination. And then you're going to put it on the dispatch center to get to your medic en route. Not your problem again, their problem. Make things other people's, that's who should be dealing. You need to deal with that patient. As is an MI patient, a STEMI patient. They can go into cardiac arrest any minute, into some sort of arrhythmia, any minute. You want to be prepared for that. I don't want you figuring out on the radio, well, this medic would be better, well, I like this, no.
Well, I get that. I'm just more or less, if I did see that, I'm going to say, like you said, oh crap, we probably got something serious. Where am I going? Am I going to the health center?
So here's the other, so the other scenario that I brought up, you're way in Colebrook, right? You're out in Colebrook. You have performed this on scene, you're still in the house, you're prepping to transport. Right. It is appropriate to consider LifeStar to Winsted Health Center for an intercept, absolutely. So what I'm saying to you is, don't delay moving toward definite
Something.
care. That's all I'm saying. I'm not gonna give you something for every scenario out there because I
It's
can't.
understandable.
Right.
I mean, it
But
just-
a helicopter intercept for a STEMI is appropriate. It is appropriate. I can tell you, up north, we do it all the time.
Are we only transporting to, like you said, in Colbrook or, you know, other towns? Would we, if the health center is the closest facility,
Mhm.
that needs to be a consideration, would we transport for a physician to look at it at the health center, or are we only transporting 12 leads to Charlotte?
You go to the closest appropriate facility. Winsted Health Center is an emergency department by designation,
Okay.
and that's all I can tell you. And you can talk to Winsted Health Center, and Winsted Health Center can tell you yea or nay, however appropriate that is or not.
Right.
But what I want you guys to think about is,
We're moving.
you're moving, you're not delaying. This is one, because people always say, well, you're doing the 12 lead, you're gonna delay care, right? So there's these typical sort of statements that are made when you do this. And I just don't wanna get into that realm. So I want you to do them, I want you to move and all of that, but I want you to consider helicopter service, right, for a STEMI, that is appropriate. And I want you to move toward ideally a PCI center with this patient. I also don't want you to be the only ones that worry about this, right? I want others to be part of this team and part of figuring stuff out. It's not just you. You got your hands full. Others should be worrying and doing stuff. Will they necessarily? I don't know that. I don't have control over that. You can control a small piece of the pie, or at least try.
So intercept point, like intercept with camping and all that, I know we were talking about this earlier in the year. If camping is not available, because half the time they're not, if
Mhm.
medic 6 is out, you're not gonna get a medic.
Mm-hmm.
Is there something in line that our dispatch will reach out?
It's not your issue.
I'm just,
Again, not your. I don't know. I can't tell you. I don't know if there's specific protocols or anything like that. You're driving toward Waterbury, dispatch knows you're driving toward Waterbury. Dispatch should know the resources that are available for you and should know the centers that they need to talk to get those resources for you. That is not your job. That is the dispatch center's job. If they don't do a good job at it, they need to look at that. We're doing the best we can with the part of our piece of the pie, right? I'm not dealing with their piece of the pie, that is what they have to deal with. You contact your dispatch center, you say, we've spoken with Met Control, they have advised we should be continuing on to Waterbury. Can you please work on a paramedic intercept? We're traveling down Route 8 to Waterbury Hospital. Thank you. Done. There's no more than that.
I'm just trying to get the best care for
Yeah,
you.
that's
all.
correct. And then, now maybe they go on, okay, so we have Waterbury Medic XYZ or whatever responding. Can you coordinate on Med 7? Different story, right? Because now you need to actually meet. But the initial request and where that medic comes from, I don't care. And I don't want you to care because I want you to focus on that patient in your care, not all the other stuff, right? Basically. And then we'll work on stuff, how can we improve things, how can we set up stuff that this works better. Okay, so once we have printed out that EKG, it comes out, we're going to basically use, it's called Scanner Mini, an app on the iPad. We're going to take a picture. It has this auto selection bluish area on here that should line up around just the strip, not the interpretation, not the wording, just the squiggly lines. Right, that's all you're taking a picture of, because it goes to a doctor. And they should be able to know what this means. So, click, button, take picture. What you can see outside of the screen is, it says save, right? This one is save. Oh, no, save and then 1. Goes from save to 1. Yes, there's 2 steps. Because this is the picture, I'm sorry, this is save here, so this is the first thing you see, save. You can retake if you need to, if this wasn't good. Save. And then this picture, this is the next screen that pops up, has a little 1 at the bottom right corner. Just click on that 1. Okay? So it's fairly simple. It's you click the button and then you sort of stay in the right-hand corner. Then you arrive at this. You click upload, the upload button. It comes up with the screen of a folder. You click on the folder. And you click on this and add. And that is it. All right, so there's a way to verify that it went I don't want to spend a lot of time on it, but basically, if you go into the iCloud, there is this folder that you actually selected, and it has something underneath that says 1 items, 0 items. You can't read it on this PowerPoint, I'm sorry about that. If it says 0 items, it went. It goes to 1 as you had placed it in there. As the software and all the systems work, it grabs it out of there, and then it's 0. But I'm not even asking you to do that. It should just work. Good? Okay. So we're going to talk about, just go through 2 case studies quick, so that you see how this all could go down from the beginning to end and why this is so beneficial. So in this case study number 1, it's a 51-year-old female, nausea, vomiting. She's sitting in her bathroom vomiting, right? Onset sudden, again, this is a pretty telltale sign, right? So she's not sick for a long period of time, but it just suddenly came on less than 20 minutes ago. She's pale, diaphoretic, and she doesn't have any pain, but when she stands up, she has dizziness, right? That's probably not good either, right? Okay. So these are her baseline vital signs. So what do we notice here? What's interesting about these vital signs?
A little hypertensive, a little tachycardic.
Mm-hmm. What else?
Her respiratory rate's elevated.
18 is probably okay.
Yeah,
Her O2 level was a little low.
Yep, yep. So she's not dramatic, right? She's not 80/60, some crazy hypotension, okay? Even so when she gets up, she gets dizzy, right? Odd. Okay. She's tachycardic. She's vomiting, so she should either be on the slow side, right? Because when you vomit, vagus nerve and all that, but whatever. So she's tachycardic, and then she's only 92%. When you look at this and look at this, there's no respiratory illness in here, right? So why is she only 92%? So some of these are, they're not like big clues, they're small clues. You just have to look for them, right? And sort of look at this. So she's probably not well right now. Okay. Diaphoretic, yeah, is another one, right?
She was
Yeah.
just diabetic too.
Yeah, so dizziness, no current pain, pale, cool, diaphoretic, so the typical, right, signs, okay. Yeah, so very good, Jimmy. It could be just diabetes, right? It doesn't have to be a heart attack. So what?
I was gonna say, not for nothing.
Yeah.
But if you didn't look closely at her actual signs,
Mhm.
her physically, a pulse of 112 with a little bit lower O2 sets
Mhm.
wouldn't be uncommon for a smoker.
Yeah, but 112 is I mean, that's
My
marked,
resting heart rate's like 100.
yeah, 100, by 112 you start getting into a range where it's a bit too much for just sitting there, right? In particular when she stops vomiting and she's just sitting there and she's doing 112, that's
Right.
probably not good, right?
If you don't look at all of it together.
Right. So what can we do about this diabetes?
There's blood sugar.
Correct. So let's say the blood sugar is 86.
Good.
So we kind of know that's probably not it, right? We're not going down that path. Okay. She has a history of hypertension. Well, maybe she didn't take her meds. Okay. History of anxiety. Okay. So no treatment prior, no history of similar events. What do you want to do there? That's what you first think,
No.
right?
Put her on oxygen.
Yes.
Put her on.
So do your regular stuff. So oxygen is great, right? Okay. What else can we do?
Gonna ask her if we already have her history.
Mm-hmm. Yeah, so you already did like sample and stuff, right?
But we're
Mhm.
also gonna ask her her family history.
Mhm, sure.
Cardiac
Yeah.
related.
Give her listen to one, see if it's the reason why she's.
What's in sample, what's the A stand for, which is not on the board right now? Allergies, right? It's kind of important to know, because what if we choose this as ACS, we want to give aspirin, we gotta know, right? So allergy, I think, is a good question, is always a good question, right? It should be very early on. Okay, all right, so let's continue. So, probably ALS, right? Intercept's not 100% clear, but okay. And then Jimmy already said this, we titrated oxygen to 94, right? So we gave supplemental, and we did in fact administer the aspirin, right? Okay, great, because it wasn't contraindicated. All right, so we did a 12 lead and we sent it to the hospital. And I don't know which hospital this is, but apparently they're looking at it on big, big screens at this hospital, which is cool. And so this is what your EKG looked like. Okay, so this is not a Zoll EKG picture, just so you know, so yours will not have this interpretation here. Yours has the interpretation on the left, okay, just so you know. So what does this say, or what's the deal?
You see the fireman sat there.
Correct.
And it states that there's an MRI system.
Correct. So, pucker factor a little bit, right? Should be. I mean, if you see this and you're not like a little concerned, then you have missed a lot of stuff, right? So you should be a little bit concerned, okay? So, we send this and they say, okay, PCI, blah, 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 and we'll go and try to, go, let's say, Waterbury. So, med control, diversion to PCI center, STEMI alert, transmit it. Okay, we just do the Charlotte right now, less than 15 minutes on scene. Again, scene time is stressed, additional tracing as requested, and then we arrive at the PCI center. Ideally, we arrive at Waterbury Hospital, same minute, whatever, and ideally we move into the cath lab. Again, all of this doesn't happen like this, unfortunately, but their end of the pie, not our end of the pie.
Potential for it.
Right. So this is actually what she had. So this is a cath lab image. They do fluoroscopy. Fluoroscopy means continuous moving x-rays, no different. It's basically all it is. It's like an x-ray movie. So I'm shooting a movie, but I'm using a camera that actually emits a camera and a sensor or cattle or whatever to do x-ray. And so when you look at this, this should have continued down here like it does here. So she has an occlusion here, okay? And I believe, Tom, this should be LED?
I think it's either LED or the circumflex.
Okay.
No, I think it's the LED.
So again, don't matter, not important, right? It was lateral, so yeah, it should have been right, but it doesn't matter. So, okay, so she has an occlusion here. They go in and they open it up and see now all this blood flow. So what you see in black, what they do is they go to the opening in the aorta, and there's an opening there into the coronary. So 2 coronary openings still, and I put my catheter right there, and then I start squirting dye into it. And that dye is what makes this look black. And as I squirt the dye in, the film runs, so I actually see it moving through the art. It's awesome. If you ever get to see it, it's really cool. And the problem is this is a still shot, so it's not as easy to see because the heart is obviously moving, in her case 112 times. Hopefully by then it's slower. But so you have this thing doing this, and so they take still images too, besides the movie run. And then they go in, and then they have this catheter, it's all part of it, go in, and then there's a balloon that they blow up. And they blow it up with an insane amount of pressure. Is it 3 times tire pressure or something crazy, right? Crazy amount of pressure. They blow up this balloon and it pushes all that crap against the wall. Okay, so all that gunk that we saw in the earlier pictures get pushed against the wall. Okay, so now it's against the wall. So now I have to help it that it doesn't just come back or do something. So then what I do is I put a stent in, so which is this metal mesh thing that just expands. Once it gets blown up and pushed, then it just stays open. And sometimes I do that all as one part process, whatever. Sometimes I have to go further in and I have another occlusion down here that I have to open up and blah, 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 right?
Do a lot of sense to you.
Yes, yes. So this is one study, right? And so this woman did fine, right? She did great. Early 12-lead PCI reduction. Hopefully her muscle tissue wasn't damaged a lot. So she can have, often they can have the same life that they had before, just after, if all of this works well. And if it doesn't work well, then they don't. Then they have heart failure and other issues. Okay, so 67-year-old male, chest pain, and so they're sitting in the kitchen, returned from carrying groceries. So some level of exercise, right? For a normal person, no big deal, right? Alex, I mean, maybe a little bit winded, but the 67-year-old is winded, right? Okay, so tightness and crushing, don't like that, right? When they're already like telling you, hey, I have something going on, you gotta do something. Okay, radiates into the left arm, even more. So this gets very obvious, right? I mean, if you don't see this, then you're like blind, deaf, and whatever. Okay, 3 nitro taps already taken, right? So he's already self-medicated, hey, I'm all good, okay. What's a good question to ask when this is told to you?
How long ago?
How long of it? Yeah, what else?
Is it yours?
Yeah, good, another, yeah.
Did it expire?
Key, how old is it? What does nitro do if you take it and it's new, it's fresh, it works? What does it do under your tongue? Generally it tingles. What does it do to your head?
Headache.
Headache.
And then
So those are good questions to ask, right? Or can you show me the nitro that you took? Do you still have that bottle? Take a look at that bottle. If that bottle reads 2011, yeah, no good, right? So this 3 is not the max anymore, right? Okay. Unfortunately, we don't carry nitro, but, okay. So these are vital signs. So let's look at this. So he's only 1.4, the other one was 1.12. Not so nice, right? It's a low SpO2, blood pressure, hypertensive. Good.
I guess unless he was super hypertensive before taking free nitro, his blood pressure is still that high.
You're assuming that the nitros worked.
That's what I said, no, by saying that, I would assume that it probably didn't work.
Correct, yes. So generally speaking, nitro should reduce your pressure, unless like what you said. What if he was 200 over something? Possible? We don't know, right? So, but yes, generally speaking, nitro will drop your pressure. In one particular MI, it can bottom your pressure out, and it can kill somebody. That, but whatever. No, they don't want to be.
We're not supposed to give it if it's less than.
Systolic less than 80.
Correct. No.
100.
100 now,
100.
something or whatever it is. 100, 110.
110 now. Used to be 80.
110?
I'm old.
I thought it was 100.
Okay,
It
so
used to
around
be
100,
80.
110.
You know.
Okay? Give some room for that sucker to drop, okay? It's basically it. All right. We gotta cut that out though, right, Tom? Okay. So he has history of hypertension, myocardial infarction, angina, hyperlipidemia. So he does a lot in his arteries already, has gunk in there, right? So this is hyper buildup of gunk in your vessels. He takes aspirin 81 milligrams a day, nitroglycinopro, atorvastatin, blood pressure, and then a statin, blah, blah. Okay, no known allergies, great, so we can do stuff. Previous MI 12 years ago felt almost the same. So that's another great question. You have had an MI, is this feeling like the other MI? And they're like, yeah, pretty much. Right? Doesn't get any clearer than that. Okay, so ALS, right? We talked about that. 12-lead acquisition, oxygen, ASA. So it becomes almost like a standard sort of rundown, you know? This is what we do, ALS, oxygen, 12-lead there, okay? All right, let's see. So, what do we got?
Well, it doesn't have necessarily typical fireman hat look.
Not quite.
No, it looks obviously different. It states.
Looks like it's
Suspected
upside down
MI.
fire.
So sometimes you have depressions. You don't always have to have elevation. That's where all of this gets very tricky, right? When you really get into it, but we don't really worry about that. I can tell you right here, this is very clear ST elevation MI, okay? And then this is elevation right here. So from here to the baseline is up. Here to the baseline, this thing to here is up, okay? So 1 and 2 is your septum, the separation in the heart called your septum, and this is what that looks at, 1 and 2, because they're on each side of it, almost. So it's a septal infarct, possibly acute, so it's kind of like, I don't know, the rest, who cares? But again, acute MI suspected, okay? So when you see that, right, should, not to the patient, right, to the patient, straight face,
To your
all good,
patient,
yeah,
to
we
your
got
partner.
this, right, I got this.
Partner.
I'm a certified hero, so we're good. So medical control, PCI diversion, additional nitro, yeah, administered PCI, tracings every 10 minutes, arrival, okay, and you go to the thing, okay, and there we go. And so this is, hold on, Timmy 3, flow, blah, 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 blah. Okay. So, is this,
That doesn't look the same.
well, no, they won't, because this is like occluded and this is freed up.
Yeah, but I mean, even the.
It's probably a little bit at a different angle.
Yeah, I was gonna say, it
Yes.
might be at a different angle,
Yes.
because it looks like this one's more of a curve, now it takes a sharp.
Yes, but all of this stuff is
Right.
not here,
It's not fair.
not good, right? Okay? Questions? No? Good. How long was that?